Thank you for accepting our invitation. This is a very great moment to share with the Miami team this moment, this webinar. Unfortunately, we would like to have him here in Morocco in person, but you know the circumstances, things are playing out now. So as an introduction, I would like to say that urologists at the end of the 19th century and the beginning of the 20th century dealt with what was commonly known at that time as prostate enlargement in its complication with either a straightforward manner, and that was a prostatectomy, or indirectly by either castration or devascularization of the gland. This is usually by analogy to uterine fibroid was done by ligating both internal iliac arteries, and the procedure was in itself very invasive and resulted in severe complication and sometimes a higher rate of lethality. With the advent of modern interventional radiologists, the procedure was revisited and refined by super selectively targeting the prostate artery without compromising the blood supply to neighboring organs. The involvement of ER or interventional radiology in dealing with prostate disorder may be in some regarded by some urology community as an invasion of their territory. But instead, we should regard this open-mindedly as a valuable addition to our therapeutic armamentarium. The right attitude toward this paradigm shift is not resist change, but rather embrace it. For this purpose, and in that spirit, we invited two of the best brain and hands to cover this topic and put us in picture with regard to the state of art of the indication, procedure, and the result of prostate artery embolization in BPH and its complication. Let me first introduce both of them, Dr. Shivank Bhatia, who is a board certified interventional radiologist at UHealth, University of Miami Health System. He's an associate professor of interventional radiology and urology, and is a chairman of Department of Interventional Radiology at the University of Miami Miller School of Medicine. He's a multidisciplinary team of clinical experts in research. He earned his medical degree of PG Medical College in Ahmedabad, India, and he pioneered prostate artery embolization in US, and he trained more than 300 physicians on the technique related to prostate artery embolization. He had a dual clinical appointment in the interventional radiology and urology. He's an expert in minimally invasive image-guided procedures to treat enlarged prostate and uterine fibroid and liver cancer. So I tried to summarize because it's very, very long resume and with a lot of achievements.
Yeah, my mistake.
Second is Dr. Issam Kably. He's a board certified associate professor of interventional radiology and medical director of interventional radiology. He was trained both in France and US with expertise in minimally invasive procedure. He provided interventional radiology procedure for the last 12 years at the Jackson Memorial Hospital, where he served as an associate medical director of the IR, and where he pioneered men's health intervention and the percutaneous spine intervention in cancer. He delivered multiple lectures and scientific presentation and published scientific articles in peer-reviewed journal on the topic of interventional radiology. His clinical interests focus on endovascular and percutaneous treatment of the prostate disease. Welcome both of you guys. That's a very excellent achievement. I can't really read through all your achievement, but it looks very impressive, and it belies your very good expertise in this subject. Before starting, I want to extend my thanks to Cooper Pharma for sponsoring this event and for providing the platform to make this event happen. So without delaying any further, I will just hand over the mic to Dr. Bhatia to start with the indication and the procedure of the PAI.
Sure. Thank you. Thank you so much for the invitation. Thank you, team. Thank you, Copper Pharma. Thank you, my colleague, Dr. Kably, who actually is from Morocco, which I always say it's Morocco's loss our gain. He's such a skilled person, physician, and a colleague that we are very, very honored to have him working with us. So thank you all for inviting me and giving me this opportunity. I'm going to go over like more of an overview of prostate artery embolization and some of the clinical outcomes as well. So this procedure, I got interested personally in 2012. And at that time, it was really only few procedures, a few cases done out of Brazil and Portugal. It's actually one of the pioneers of interventional radiology, Dr. Pisco. As per my understanding, he started doing this when, unfortunately, his brother had a severe complication from a TURP procedure. And he was already a pioneer in uterine fibroid embolization at that point of time. And he went on to do over 1,000 prostate embolization procedures. And unfortunately, he passed away a couple of years back at Society of Interventional Radiology meeting. So first of all, I want to tribute to him, for introducing this to the world, and Dr. Carnevale from Brazil, who is also a dear friend. We got involved in around 2014. Now we have treated over 800 men with this procedure, one of the largest experience in United States and pretty much second largest in the world at this point. So again, it's an honor for us. We are really blessed to be in this particular area and role to be able to help so many people. So I'm going to share my screen. Is everyone able to see the screen?
Perfect. Yes.
Perfect. All right. So I'm talking to a group of urologists. So obviously, I'm going to be very cognizant of that fact, and I'm not going to discuss all the basics of LUTs and BPH and the patient workup and the uroflow and the urodynamics and all those things, because that's not right. Me discussing all those things with you guys. So I'm just really going to focus on prostate artery embolization for BPH. So what's the rationale? Why embolization for an enlarged prostate? So we delved into uterine fibroid embolization around 1996, and by 2004 it was FDA approved, and then now it's considered to be a standard of care. So why did it take us such a long time as an interventional radiology community to figure out that what we have done in fibroid space we can do in prostate space as well? I think the answer lies in the anatomy and in next few slides, that this is a technically very, very challenging procedure, and to be able to perform a safe embolization without affecting the surrounding organs like bladder, rectum, penis, I think is the key. So definitely the procedure involves, I won't say significant risk after the experience we have, but, a significant learning curve. So what's the rationale? Why embolization? So BPH per se, it's a hypervascular condition, though it's not malignant, obviously, as we know. And with embolization, we aim to cause ischemia, which has a triple action. One is reduction in the size of the prostate, reduction in the consistency of the prostate, as we know that as the hyperplasia develops, there is well-defined the nodules which develop in the transition zone, and those nodules have a stromal component, so they are pretty hard, as well as they are hypervascular. And the third effect is reduction of the hormonal action. So the effect leads to urethral decompression, decrease in the smooth muscle tone, and reduction or altered disease progression with improvement of urinary flow and symptoms and quality of life. So around 2007, there were 2 or 3 animal studies which were performed of feasibility and safety of prostate artery embolization in dogs. And a consistent outcome was 40% reduction in prostate size on CT scan, and it was well correlated on pathology and imaging without any major non-target side effects in bladder, rectum, and other organs. First intentional clinical use, 2010, in 2 patients, and then those were followed up in 2011, and that was our first exposure to this particular procedure. So diving right into what makes this procedure challenging, I'll go over the basics of prostate arterial anatomy, so we understand what it takes really to perform this embolization in a safe fashion. So this is an angiographic image of pelvis, and it's an ipsilateral oblique image. So we are looking at from an oblique perspective, and in this particular case, um, I'm going to show in a second, but every time we do this, we have the anterior division and the posterior division of the internal iliac. And we always identify the three vessels: obturator artery, internal pudendal artery, and inferior gluteal artery. And in this particular case, the prostatic artery is arising right there from an inferior vesical origin with the green mark on it. But the other potential origins are arising from the anterior division or the gluteal pudendal trunk or the internal pudendal. These two combined are 50% of the origins. Inferior vesicle is 25%. Obturator is another 15%. And then there are some other rare origins. So these are the common origins which we deal with on day-to-day basis. But also it's important to understand in terms of the vasculature from our perspective, from an embolization perspective, that there are urethral branches or the BPH zone or the transition zone branches, and then there are capsular branches which are supplying the peripheral zone, and some of these pass on to rectum and anal canal. So this is like a picture image, but on the angiographic image, it's a very nice correlation of the hypervascular flow to the transitional zone, and then that's the peripheral zone flow. So some more ideas about the identification. We start with 30 degrees ipsilateral oblique. We use Foley catheter. We used to use Foley catheter. Now with experience, we no longer have to use Foley catheter. It arises from anterior division. It's almost never a first branch of internal iliac. It has a tortuous S-shaped course towards midline, and almost inevitably it crosses the obturator, which is when we call it as a crop sign, a crossing obturator sign. Or if it's an IPA origin, it will cross the femoral head on an oblique image. We do see corkscrew vessels supplying the hypervascular BPH nodules in the transition zone or the median lobe, and that's another way we identify which branch is actually supplying the prostate. Around 80 to 85%, it's a single artery on each side. Another 10 to 15% is dual prostatic artery. So there, which means there are two different arteries supplying the transition zone. Another example of prostatic origin. So these are the branches to bladder. The orange one, branch to prostate, rectum, and IPA. And we always see this pattern, which obviously makes anatomical sense, that there's ipsilateral oblique. So we'll see bladder, followed by prostate, followed by rectal, followed by internal pudendal artery. So this is an inferior vesical origin example. Again, the incidence remains around 25% in our experience. The second one is internal pudendal origin. In this case, again, the bladder origin first, or bladder branch first. Second is prostate. Third is rectal. And then fourth is IPA. So selective injection, this is what we like to see, an hypervascular blush within the prostate or the left hemiprostate. And we can confirm this on what we call as a cone beam CT, which means we are able to perform a CT scan during the procedure after putting a microcatheter or small tiny catheter into the prostate. And we inject some contrast and we do a CT scan, which actually shows that, okay, we are supplying only the prostate and nothing else. So internal pudendal origin incidence is around 50%. And the third one is the obturator origin. In this case, again, the green one. And this origin is around 15%. So it's very important for us to selectively use very tiny microcatheters and get into this. In fact, me and Issam have worked with a lot of companies to design specific smaller catheters which are used towards specifically prostate embolization. Anatomical variants, I think, are very important, but I'm going to breeze through this. But just to show that, why technically the procedure can be challenging, this is what we call as corona mortis, or an empty pelvis sign, where there is no obturator artery on the internal iliac injection. And the obturator is coming from external iliac, and the prostate actually comes from obturator artery coming from external iliac. which I think is important, in cases of trauma, but also in sometimes in cases of when performing prostatectomy. And obviously all of you are aware of this variation coming from external iliac artery as well. So accessory obturator is applying known as corona mortis. The other variant is terminal internal pudendal supplying the prostatic. Rare, I've seen like 3 or 4% of cases, but again, something which we would not want to miss, and specifically in smokers. So this is the critical part in terms of potential anastomosis and potential non-target embolization risk. The risk is to the bladder, blood flow, penile, and rectum. In fact, the major risk remains really only for penile. The bladder and rectum are pretty safe. The only way you can or anyone can cause complications related to bladder and rectum is if you are selectively into those branches and you embolize those to stasis. But few small particles into bladder or rectum blood supply does not cause any clinical consequence except some small amount of blood in urine or in stool. But penile is the major one. We have performed over 800 of these procedures, and we have seen, I would say, like 5 or 6 times non-target embolization to the penis, and all of them have healed completely by just using topical therapy. So the first example, again, the prostatic artery, in this case is right there, but there is a big branch supplying the bladder. So our goal is really to position the catheter distal to the bladder branch origin. And if we are not able to do that, we use a very small coil, usually around 2 millimeter coil, to protect the bladder flow. Same thing with the penile. We like to make sure, obviously, that there is no non-target or embolization or particles going down to the penile supply, and especially in the accessory pudendal origin. And you can see on cone beam CT, it's a very, very impressive, the blood flow to the penis coming from the prostatic artery. And in this case, we place a coil just in the mid prostatic artery distal to all the actual branches to protect the flow or protect like any kind of particles going down to the penis. Penis has accessory pudendal as well as internal pudendal, as well as the other side accessory and internal pudendal. So we have done a study whenever we have done this coil embolization, it has not led to any kind of erectile dysfunction later. To rectum, as I mentioned, it's more common, especially from the peripheral zone branch, but it's safe really as long as we are avoiding the major rectal supply. So if this is really the prostatic artery just in a line diagram, the yellow one, and all the intraprostatic branches, whenever we see communication to penis, either going through the gland or through accessory pudendal, we prefer to coil those for 100% of cases. When it comes to rectum or to bladder, if we see a significant risk, then we will use coils, very small coils to protect those branches. Now, this is an animation which shows how the procedure works. We put a small catheter through the groin or through the wrist. We actually do 95% of procedures through the wrist. And then we thread this small microcatheter, go all the way selective into the prostatic blood flow. And once we see we are in a good position, then we inject these small spheres, which are essentially made up of polymer coated with gelatin. These particles always stay within the prostate. They do not move. They have a positive charge on it. Our blood vessels have a negative charge. So they are embedded in the prostatic blood vessels forever. Once we are selectively there, we inject these small particles, and we want to make sure that we are not doing it too fast. So usually we inject 1 to 2 cc of mixture every minute. So it takes around 10 to 15 minutes to perform just the embolization. And the way the particles comes, we dilute them with 10 cc of saline and 10 cc of contrast. This is a good important concept about the perfected technique, that once we get complete stasis, there is no more forward flow. Sometimes there is still distal flow, we are just not able to see it. So we advance the catheter distally into into the gland, and we are able to inject even more particles. As you can see in this animation in the video, coming in, the particle, the catheter going now more distal. So we are injecting some more, couple of cc more there, and then we pull the catheter back and we inject more particles on our way out. So these are like, we are talking about thousands and thousands of particles, and the diameter of these particles are somewhere between 100 to 500 microns, which is essentially diameter of the hair if we were to cut our hair and then, you know, cross section. So we usually inject around, you know, 1 cc per 10 cc of the size of the gland, and if it's a 100 cc gland, we will end up injecting around 10 cc on each side. And then we confirm this on cone beam CT at the end to make sure that we have very good distribution of the particles into the prostate. So as I mentioned, you know, most of these procedures we perform through radial access through the wrist approach. The procedure is an outpatient procedure done under conscious sedation. It takes around, you know, 1.5 to 3 hours. I think this slide is 2 years old. Now all the cases are under 1 hour. Wrist or groin access, X-ray guidance. Our technical success rate, which we label as bilateral embolization, is more than 98%. No Foley catheter is used anymore for these procedures, unless patient has a history of very high post-void residual or recurrent UTIs or recent history of urinary retention. It's been just so I'm going to show this video quickly just so that, you know, we go over how the recovery is after the procedure. 3 to 7 days of burning, urgency, bladder spasms, mild to moderate pain controlled by medication, mild blood in stool or urine. We encourage normal fluid intake. It's been just 2 weeks since my procedure, and I can tell you I am a different person now. The first time, actually, I got on a plane on Friday, just 10 days afterwards. I didn't have to get up off my seat on a 3+ hour flight. It was great. Anyway, basically, you really prepared me well. The first 5 days, yeah, you had the cramping that started to go away. The burning was probably the last thing that stayed. And by 7 days, I felt a change. After 10 days, the change was even more rapid. And I feel like I said, I'm a new person. My definition of urinating was stop, dribble, stop, start, all kinds of random, all kinds every few hours in the middle of the night. Now, it just start and stop, and I'm done for the night. It's great. And from what you said, the best is yet to come in a couple of months. But what a change. I feel I'm in New York visiting. I just had a grandchild. I'm walking the streets. I don't have to run into any bathroom. Well, anyway, thank you so much. It's been really wonderful. Thank you for you and your team for making me. So this is how most of our patients do, especially the one with the larger glands. You know, more than 90% of patients have this kind of experience. When it comes to complications, no need for urinary catheter, no need for any CBI, obviously, no hospitalization, no transfusions, no antiplatelet, no worrying about like taking people off antiplatelet. Going through wrist, we are able to treat patients on anticoagulation. No risk of retrograde ejaculation, no erectile dysfunction, no incontinence, no urinary stricture. Symptom improvement begins at 2 weeks post-procedure, significant improvement at 4 weeks, peak benefit is at 3 months and remains persistent. Right now we are evaluating our 5-year data. Expected outcomes, 90% success rate defined by 70% reduction in the IPSS score, which is pretty standard for TURP and HOLEP. 30 to 40% reduction in prostate volume at 3 months. Post-procedure, post-embolization syndrome, you know, including pain, nausea, vomiting, some burning, urgency, some rectal spasms, you know, people can get some hematospermia, penile ischemia, that's very, very, very rare. Balanitis, extremely rare, but these are like, you know, the other ones are the expected complication. And we give anti-inflammatory, we give antibiotics, we give pyridium, vesicare, and Dulcolex for constipation. That's our standard regimen post-procedure. I'll quickly show a case, 62-year-old male with history of green light surgery 4 years back, IPSS 28, QOL 6, Uroflow 3 ml per second, PVR of 170 cc, enormous prostate, 380 cc with a huge median lobe, And obviously patient did not want to undergo a green light or his only option was really HoLEP or prostatectomy. So he was referred to me for embolization. We performed the embolization, successful, no issues at all. 3 months later, his prostate went down to half the size. Most of his median lobe was gone. It was dead. And at 3 months, the IPSS score was 6, quality of life 0, post-void residual down to 50 cc. I just saw him for 2 years follow-up, no recurrence of symptoms. So obvious indications for intervention for BPH related lower urinary tract symptoms. Absolute remains urinary retention, recurrent UTI, renal insufficiency, and gross hematuria, and that remains same for PAE. Relative indications, moderate PVR volume, moderate to severe symptoms. But PAE specific, men really wishing to avoid sexual side effects, poor surgical candidates, failed surgical procedures, large prostates more than 80 grams, and I can vouch on that 75 to 80% of my practice is more than 80 grams. Hematuria and urinary retention. A lot of people come with urinary retention post hernia repair, post any other surgery, and they're just not able to get out of retention. When do we say no to PAE? Very small prostate size, less than 40 grams. Very large median lobe. The case we saw was very large median lobe, but he already had a green light before. But if they come to me just with an extremely large median lobe, with especially a figure of 8 appearance, then I stay away from it. Predominantly irritative symptoms, predominantly overactive bladder with no real voiding symptoms, very high post-void residual with no symptoms, which probably is pointing to an underactive bladder. Severe peripheral arterial disease with CT angio showing poor vascularization, very rapid regrowth of prostate despite good initial response. Clinical outcomes, as again, you're a group of urologists and you're aware 70% is what TERP gives us, 15 to 17 point reduction in the IPSS score, quality of life 70%, Qmax improvement 125%, and PVR reduction is around 77% with the very, very very impressive low retreatment rate of 12% at 5 years and 15% at 10 years for a TURP. When it comes to the minimally invasive surgical therapies, most of it is around 40 to 50% in terms of IPSS reduction, which translates into 8 to 12 points except aquablation, and Qmax improvement by 50%. So where are we with prostate embolization? We look at the systemic review meta-analysis of initial studies, around 484 patients, 7 studies. Rather than going into micro detail, the bottom line is 70% reduction in the International Prostate Symptom Score. And I think an important point here is, this early experience and the meta-analysis was really spread over a wide variety of prostate volume. But having said that, I think there is a strong preference now for using prostate embolization in especially large glands, more than 80 grams. And that's where there is the widest adoption or the most amount of adoption from our urology colleagues. I mean, I work with at least 30 plus urologists in South Florida, and all of them really send me more than 80 gram size glands, especially more than 100 grams. And I get a lot of referrals for hematuria, urinary retention, acute retention, and so on, so on and so forth. So again, 17-point reduction in the IPSS score. I'm just in one slide, I'm summarizing, all the different studies which were done in last 5 to 7 years, which were comparative studies of PAE versus TURP or any other randomized trials. And most of those studies showed between 10 and 20 point reduction in the symptom score, with 20 point being an exception. But I would say it's more of 10 to 12 point reduction in the symptom score in most of the randomized controlled trials, and most of them actually did not prove non-inferiority to TURP. And again, the point I'm trying to make is that when it comes to smaller glands, TURP is the king. Less than 50 grams, TURP is the king. 50 to 80 grams, I would say the results will be comparative if we were only going to evaluate that subset. But when it comes to larger glands, more than 80 grams, I think embolization is as good as anything equivalent to TURP for larger than 80 grams, which is mainly a HOLEP or an open prostatectomy. This is our experience, which we published a couple of years back of 93 patients, more than 80 grams. And we saw around 15-point reduction, 22.3 down to 7.3 at 12 months, around 70%. But if we look at the prostate volume reduction, 40%, PSA reduction by 70%, post-void residual reduction by 70 or 69%, and Qmax improvement by 66%. And how many patients were IPSS more than 13 during follow-up remains around 15%. How many patients remain on medications or are able to get off medication? Around 85%. So very similar to these numbers. Around 15% of patients stay on medication after embolization. But another important thing is the IIEF-5. We actually saw an improvement in the IIEF-5 or the SHIM score after embolization at 12 months. And we just presented our long-term outcomes on the sexual side effects after PAE at Society of Men's Health in United States, and we were actually awarded the best abstract. Rest of the adverse events are really expected, dysuria, urinary frequency, urgency, small amount of hematuria, urge incontinence, fever, everything is expected and very minor, and everything resolves within 5 days. This is a comparative outcome of all the larger than 80 grams compared to ours. And you can see that, the variation is really between 50% improvement in the symptom score all the way to the 80%, but it's consistently around 65 to 70% and 12 to 16 points. A randomized clinical trial of prostate embolization versus a sham procedure was published in EAU last year, which definitely showed that PAE is not inferior to sham, and showed all the patients who received sham did not show any improvement, and after the blind period they were all treated with PAE and showed a significant drop in the IPSS score after they received PAE in the open extension period. So very, very impressive outcomes again on PAE versus sham, and showing around 13-point improvement. Difference between PAE versus sham was 13-point difference in the IPSS score. So PAE showed 17-point improvement, sham showed only 5-point improvement. Still, there are some limitations in the data. Many of these are single center series, and we do understand that and acknowledge that. We just presented a series of 576 patients, which is going to be presented in next month at Society of Interventional Radiology. We understand many of these are uncontrolled and non-randomized. We also understand that many of these studies report redundant data, and there is some technical disparity, and there is some lack of standardization of outcomes as well. Particle type, what type of particle should be used, what size of particle should be used. Nonetheless, PAE does remain a very effective and very tolerable procedure in the world of like the entire paradigm of surgical therapy for BPH world. And there is definitely some very niche applications, patients who are in acute retention, patients who have recurrent hematuria, patients with a larger glands, patients who already had previous surgeries, patients who just do not want surgical procedure and who want to preserve, sexual function. Those are all the patients who do consider PAE as a first-line therapy. Thank you very much for your attention. And again, thank you really for the opportunity.
Great. That's very interesting. It's very excellent presentation, Dr. Bhatia. And I think we'll ask some questions before going to the next speaker.
Sure.
I have just one question from the audience that it's about the size of the particle used. Is it 500 or 700?
No. 500 to 700 is actually too big. It should always be less than
the actual size of particles.
So we use, for small glands, we use 100 to 300. And for larger glands, we use 300 to 500. But I think, for if
Okay.
someone is starting off, I would say I would recommend just use 3 to 500 of embospheres. I think that's the safest way to go, because with the smaller particles, the risk of non-target embolization goes higher. So I recommend 300 to 500 only.
Okay. So why you privilege the wrist rather than the groin in your procedure? So it seems that the route is very long going through the
Yeah,
wrist.
so we started using wrist, in 2016, and we realized very quickly that it is very easy to use the
Mm.
wrist, and it's actually much more favorable because you're going in the direction of the flow. So, going down into the internal iliac and going from one to the other side. So, in fact, our procedure times reduced by almost 30 minutes by switching from groin to the wrist.
And going to the aorta, going down to the iliac artery, and
That's
from
correct.
the
So we are bypassing the heart, right? We
yeah,
are going through the subclavian artery to the aorta directly. So we are
yeah.
not going through the heart. So that's,
Okay, not the
yeah,
yeah, there's through the subclavian to the
yes,
aorta. Yes.
absolutely.
Uh, what the you don't need you never put a polycatheter post procedure. You say
We
so.
do only
There's
if
no
we do if, like, the patients do not want to undergo the recovery. They don't want, like, the burning. They don't want all those things. And if the patients have a post-void residual of more than 300, which by definition is chronic retention, then I do not. I prefer to use a Foley catheter for 5 to 7 days.
okay. Can you do the redo? This is a question from Dr. Qiyasi. Can we do the techniques a second time if we fail the first?
Yes, you can. So I think I'm really conservative when it comes to that. I do encourage always them to consider other options, and I work very closely with all my urology colleagues. And only if patients really want it to try second time, I would. But if someone got it like 7 years ago, and now after 7 years they are having recurrence, yes, absolutely, we can do re-embolization.
So there should be some time delay between the first and second procedure.
Yeah, yeah. I would.
Uh,
I
so there is
don't do it like right away. It's
a minimal
at least 3 years,
requirement,
at least 2 to 3 years.
2 to 3 years. Yeah.
Yeah.
Is this actually the procedure now? It's open to everyone. I think there is no contraindication. I mean, it's not. We privilege patients with comorbidities that not fit for
Yeah.
surgery,
No,
and
no,
it can be done to anyone.
it can be done to anyone, but again, as I said, I'm even after having such a large experience, I'm still relatively very conservative when it comes to smaller glands.
I think
I do
in the
encourage
beginning
them.
you start with the
Yeah, yeah,
patient that are not
yeah.
very
Mainly large
yeah,
glands.
not
Like,
candidates for surgery, and then you extend it to a large population.
yes.
Okay, this is a unilateral procedure. You do one side only. How
Always,
can
always
you be
both.
sure that the all blood supply to the gland is interrupted and it's you do it only? Yeah.
No, 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 no. We do both sides.
Did you hear my question?
Yes, we always do both sides.
Okay.
Yeah,
Yes.
yeah.
Okay. So
We always do both
that's a
sides.
bilateral.
Our success rate of doing both sides is
And
98.
is there is any issue with the any issue with renal function? Yeah, any with the compromising the renal function if you do both, and the procedure was very lengthy, and in
No,
especially in frail patient with
no. So
comorbidities and
yeah, so that is a very good question for actually Dr. Kably, because he has pioneered, doing this with carbon dioxide. So he does not even use dye many times, or he use a very small amount of dye.
iodine. Yes.
Very small amount. So on an average, we use less than CT scan, the amount of iodine, very small amount, less than routinely we use around 100 ml of iodine, but we can do this with less than 20 ml of iodine, both sides.
Okay, this is another question. I think you responded this through your presentation. Uh, Do urologists refer patient to you?
Oh, 100%. Like
Yeah. So,
75% of my patients are sent to me by urologists, and most of them in South Florida. So as I said, I work with around 30 urologists at this point. And I perform around 200 to 300 procedures every year.
here, okay. So any major complication secondary to this embolization, like hematuria or
So the major,
prolonged retention or bladder
yeah,
necrosis or anything
yeah. So
that pop
retention,
up during the procedure, yeah,
yeah,
after the
yeah,
procedure.
yeah. The risk of retention remains 1%. 1% risk of
Yeah.
retention. 1% risk of bad infection needing IV antibiotics and stuff. But
Mm.
they already have a history. They have a history of recurrent UTIs. So we kind of anticipate that we put them on strong antibiotic for 14 days, and no bladder necrosis, no rectal. We had four, and I think Issam had one. 5 cases of penile ulcer on the tip of the penis, which all of them
Okay.
healed without any surgery. All of them healed with the topical lidocaine and topical steroid.
So what's the ideal scenario? The patient gets in the morning and they get the procedure, get discharged in the afternoon, and
Yeah. So
everything is all
yeah,
right.
yeah. So it's
So that's the usual
1:30.
outcome. Yeah.
It's 1:30 p.m. and I finished two already, and they all both are home.
Okay. So do you have any special instruction if anything happened during the night, who's to call and what to do?
My cell phone,
Is open all the time.
all the
Great.
24/7. Yeah,
That's
I don't like to
protocol.
bother my urology colleagues. It's that's not the way to build a practice.
Of course, yes. So it's a very interesting presentation, Dr. Bhatia.
Thank you very much.
And thank you very much for this
No, no, it's my honor.
excellent
Thank you.
experience you had of this condition. So we'll move to Dr. Issam Kably and we'll listen to him regarding the experience of your center.
Yes.
Issam, it's up to you.
Thank you. Thank you, Dr. Abouelfadel. And I hope you understand why I made sure to invite Dr. Bhatia, because he did all the heavy lifting.
Yeah, he came to Morocco.
Yes, so just to give you a quick background. I've been working with Shivank for the past more than 10 years. Extremely talented physician. And he, under his initiative, we started the PAE program at the University of Miami about 7 years ago. And at that time, I thought it was just going to be just another procedure. But it turned out to be a procedure that has a significant steep learning curve because it requires a certain expertise and knowledge in terms of the anatomy and microcatheterization. So what I'm going to be sharing with you, and hopefully also answer one of your questions that you asked, Dr. Bhatia, is the role is, does PAE cause hematuria, or does PAE is a significant adjunct therapy for you urologists in terms of hematuria? So hematuria must be something that you encounter in your daily practice. It's a common problem. It is essentially associated with benign prostatic hyperplasia, but also can be seen in various causes like cancer, for example, radiation therapy, trauma. When left untreated, it can be really a pesky situation. It can cause a significant and protracted problem for patients. And when it does not resolve to conservative therapy, then it becomes what we call the refractory hematuria, which can be a serious condition and sometimes even life-threatening. So what I'm trying to share with you is the evaluation of our single institution experience when we evaluated PAE in terms of safety and efficacy for treating intractable hemorrhage of the lower urinary tract. So essentially, this is something that we're going to be presenting in the SIR next month. And numbers keep changing. So I'd like to invite you just to focus on the overall trend, not at the detail of the numbers that not all of them are updated yet. So work in progress. So essentially it's 82 consecutive patients that we have been treating. And we realized that hematuria presents in two different groups. We have either a group that comes to us with a refractory hematuria, this hemorrhage that is so serious that usually these patients are admitted in the hospital, receiving therapy, receiving transfusion, etc. And there's another group of patients that present with recurrent hematuria. This hematuria is a lower intensity, but tends to recur over a long time, long period, and can be very difficult on the social life of those patients, not to mention that they may need protracted treatment. We looked at the endpoints in terms of mainly resolution of the hematuria, but also the improvement in blood requirements. And down the line, does PAE improve the cause, the underlying cause, like, for example, BPH, in terms of symptom improvements? So the main cause in our series remained BPH on these patients, followed by either cancer etiology, whether invasive cancer in the bladder or the prostate, and other causes were also recorded. Some of our patients came to us straight from our urology colleagues, sometimes straight from the operating room where they were doing a TURP, and they call us, hey, this patient have an intractable hemorrhage, can you help us? So we bring them, we do the PAE. And when we looked at those patients who had, and we published on that, they had hematuria following urological instrumentation, we found that surprisingly, a Foley, a simple thing like a placing a Foley can induce hemorrhage, and sometimes very serious. Followed by that was Foley removal. When I say by Foley removal, sometimes it's a traumatic Foley removal, a patient in the ICU, he doesn't know, he's not aware, and may pull his Foley. And other causes were like as follows: TURP, nephrourethral placement, etc. The technique has been detailed by Dr. Bhatia, so we use the same technique for hematuria as we use for treatment of BPH. Initially, our practice was femoral, then we kind of moved almost all our procedure from a radial axis from the wrist. We use the selective embolization, bilateral, use the perfected technique, we use the embospheres, and we use the coil embolization as needed to prevent non-target embolization and to secure the procedure. So essentially the same technique, is just the indication was PAE. We use, of course, cone beam CT, which is like a CT scan done during the procedure to tell us exactly where we are. This is a very important to secure the procedure. And we looked at the several defined parameters in the study to see if we were efficient or not, like the early clinical success, how fast are we able to stop the bleeding, and were there any rebleeding throughout the follow-up, and also we recorded the complication. The patients who were admitted in the hospital were followed based on either our own observation or the observation of the referring physician. We looked at their laboratory values. We determined if they were in need of more transfusion, etc. And when these patients were discharged, we will do a follow-up with them according to a set protocol, usually at 1 month and 3 months, either with interventional radiology clinic or the urology clinic. So this is our kind of rough results. We have a high rate of technical success rate, as well as an immediate clinical success rate. The time of resolution of hematuria in this patient was very rapid, 1.5 days in general. And when we say 1 day, it's really because we wait until the next day to go check on the patient. And that's why we say 1 day. In reality, those patients, I'm going to show you some case, may stop immediately bleeding on the table. And we had some case of recurrence, and mainly the recurrence of bleeding happened in those patients who have advanced stage cancer disease. This is just kind of summarize a little bit the clinical success in the two groups, as well as the resolution, improvement, especially in the case of intractable hematuria, both in the hemoglobin level and the blood transfusion requirements. We also looked at their improvement in terms of prostate volume, lower urinary tract, those patients were in retention. We looked at the volume reduction of the prostate and also the PSA, and there was improvement. Regarding the complication, most of the complications were self-limiting, as it is the case in PAE in general. We didn't have any serious complication. This is just a chart to kind of summarize a little bit the improvement, those patients who received PAE did not need to be transfused. As well, this chart shows a little bit the improvement on hemoglobin level post the procedure and decreased prostate volume. Now, when we do PAE for hematuria, you have to expect the unexpected. The reason being is like you're treating a patient who may come to you in a emergent situation, meaning we did not have time to work up this patient to see if he has inclusion, exclusion criteria, etc. So this is a typical case. Patient come to us, intractable hemorrhage. This is undergoing active bladder irrigation. He will need, he's being transfused. This patient is difficult because this patient is not your typical BPH patient. He is actively bleeding. He is a little bit agitated. He has pain. He's evacuating clot from his bladder. He cannot stay in an immobile position because this procedure is very precise. So we need the patient not to move during the procedure because we have the angiographic map, but still we were able to manage to treat him. This is the angiographic appearance. I'm showing here, this is the prostatic artery. This is the pudendal artery. So we do the procedure on both sides. This is the right prostate, left prostate. The cone beam CT show us the enhancement of the lobe of the left lobe of the prostate. And we finish the procedure by treating the recurrent branch coming out of the IPA, which if we come back to the slide here, you can see the urine clearing in the Foley catheter at the end of the procedure while the patient is on the table. Another case here of a patient who has 80-year-old, has so many comorbidities. He has myocardial injury, is on dual antiplatelets. He cannot have any surgery. This is how we do the procedure from the wrist. This is the Foley on the table before. At the end of the procedure, you can see the urine is already clearing. So, and the patient was discharged home the next morning. So PA is really interesting in those cases who have absolute contraindication to surgical procedure. This is how his angiography looked like. And we have a super selective catheterization of the left lobe of the prostate. This is the equivalent on the cone beam CT showing enhancement of the left lobe. We do both lobes. We inject particles. So his technique is essentially the same. This is a CT scan prior the embolization. What I'm showing here is the clot, the blood clot in the bladder. And during the follow-up, CT showed also decreased size of his prostate gland. Another spectrum of patient that we treat are those who have advanced cancer. So this patient come to us with he's a physician. He had an advanced stage 4 prostate cancer, invading the bladder, invading the seminal vesicles. His problem was a long chronic hematuria for many months, requiring repeat blood transfusion. His problem was solved quickly with PAE. We were able to do a selective embolization of his prostate. So when we do that, it's important to know the anatomy, know the variants. Our group was the first one to publish about the accessory pudendal artery and some of the variants that may be known to you guys, urologists, but we realized that our community of IR were really not familiar with that. The knowledge has increased. This was early in the experience. This is the accessory pudendal. Now we are much more familiar, as Dr. Bhatia said. In this case, it's accessory pudendal going straight to the penis. What we did here, we put a coil to redirect all the flow exclusively to the prostate, and the patient was treated with no problem. Our group also has published in terms of the coil embolization. This is a paper published by Dr. Bhatia a while ago, where we use basically coil to protect the other territories to prevent complication, such as in this case, this is the prostatic artery. We are in the left lobe of the prostate, but you can see a branch collateral going to the penis. So what we do here, we put a coil and basically the blood flow will be just concentrated on the prostate. So the same concept can be performed for the bladder, for the vesical vessel, the penile vessel, but also the rectal vessel. So what is the challenge and limitation? Like I said, when we treat in hematuria, we really don't have the luxury to select the patients. They come to us, they are on the table, they may be bleeding, but the problem, some of them may have atherosclerosis, peripheral vascular disease, whether this extreme tortuosity of the vessel or maybe also sometimes the pre-occlusive plaques can be a limitation. But we'd like to give the patient a chance, even in those extreme cases, and even sometimes, even if we do only one side, it can be beneficial to help those patients. Having the right armamentarium and tools is important. It's not just the physician. It's very, very important to have the tools to back you up when you do this procedure. So we have developed over time some preference, and we now with the expertise, we know what microcatheter is the best in what situation. To answer your great question, Dr. Abouelfadel, you asked about the if there any risk for the kidney function. This is a great question. Again, you have to realize that our group is a high volume and high experience. So with experience, we use less contrast. Okay, so that's one thing. And the second thing, we have been investigating the use of CO2 as an alternative contrast media to iodinated contrast media. So CO2 is a gas that we breathe, that we make about 200 cc every minute, otherwise we die. So we can use it to image the vessel. So this is a case of a giant prostate that was measuring more than 700 cc that was treated exclusively with CO2. Both this is the right prostate, this is the left prostate, and this is the gland. This is the just the empty pelvis sign that Dr. Bhatia spoke about. I'm just gonna skip for now. What about malignancy? Malignancy is can be treated in a very useful fashion, especially while those patients who have advanced stage disease, like in this case, who had both bladder and prostate invasion. So we have been also, our group, investigating treating with the same technique, same material, cone beam CT, same particle. The key here is to be super selective and to target the mass that is causing the bleed. This patient had multiple problems. He came with an advanced cancer, compressing his veins, causing obstructive uropathy and intractable hemorrhage. So in one session, we were able to treat his veins. We can do thrombectomies, remove the clot, place a stent, obtained access in his kidney. We did the embolization, we placed the port. So that's the main advantage of IR is the percutaneous. It can treat even these sick patients. What about the size? The size, when it comes to hematuria, the small prostate as well as the large prostate can make you bleed. So yes, it's true. It's a little bit more difficult to do it in smaller prostate, but it is beneficial in our experience. So we treated here a small prostate patient with prostate cancer. He has bone metastases. And on the other end of the spectrum, we treated also what we call giant prostate. In this case, it's 700 cc's. What about bladder stone? Bladder stone was considered, an absolute contraindication to PAE. However, this patient was referred to us by his urologist. He wanted to shrink his prostate before doing a surgery on him, acystolithopaxy. We did the PAE for that purpose in preparation for surgery. The patient also was suffering from hematuria, chronic hematuria. However, the patient called us 48 hours after the procedure because he was screaming on the phone. He was able to eliminate all his stones, and you can see his over the period of time, his IPSS, shim, all improved, and his prostate volume has shrunk. He had only one stone left, for which was much easier to remove surgically after this procedure. Our group published also a review paper. We looked a little bit at the cause of the prostatic hematuria, and we kind of hypothesized, and it's something that has been known in the urology literature since Dr. Foley. It seems that there is an androgen controlled growth factor that are responsible for angiogenesis, especially in the suburothelial prostatic urethra, and that can explain why these patients tend to bleed when you put a Foley in or Foley out. So they are particularly vulnerable to that. And if any one of you asked the question by curiosity, do we see anything different for patients who are actively bleeding during, because once you do, like, for example, an angiography for a bleeder anywhere in the body, we have some signs. We can see extravasation. We can tell, okay, this patient is bleeding. We really don't see anything different, even on the patient that are actively bleeding. We didn't see any active bleeder or extravasation. And that's why this is a more a rationale in favor of embolizing the whole gland, as opposed to try to selectively go after one single vessel. So when we started the experience, there was not much described in the literature about PAE, specifically to treat hematuria. All we had is older series that were basically, so embolization is not a new concept. It has been done since the 1980s. But at that time, they were not doing PAE. They were doing non-selective embolization. They would just go and block the whole pelvic arteries. And not surprisingly, when you do that, the less selective, you will have more risk of causing ischemia in the other organs, in the nerves, in the bladder, or you will have recurrence. So, however, when we do PAE, we notice that not only we have much more efficacy, but the complications were much less. So now the groups, now this is just a review paper that we just published, and we looked at what other groups are now starting to publish experience using PAE in hematuria. And essentially, I'm not going to go into detail. Their results mirror what our experience have shown, that essentially here in this chart, we can see from Dr. Ayagari, in the first row, you see here's representing gross hematuria in orange, severe hematuria in 55 patients, and yellow is basically clear urine. So immediate control of the bleeding and the hemorrhage, and a sustained result over time, over a period of 36 months. So again, from Dr. Tapin from the UK, they published about hyperplasia and cancer. Again, the same thing, high rate of success, both clinical, lower complication, provided, of course, that you have a physician that can do this super selective work. So just to summarize, classically, this is a classic workflow of how a patient comes, is bleeding, and he presents for medical management. Initial recommendation will be to limit the physical activity, to avoid the mucosal ulceration, do a continuous bladder irrigation. And for the patient that don't respond, they may have to undergo or receive blood transfusion. One medication can be applied also to help those patients, either 5-alpha reductase, anti-androgen, or some medication to help with the prothrombotic medication or luteinizing hormone release. If the patient responds, great, we are done. If the patient does not respond, then we go to surgery. So what are the surgical alternatives that we have? I think you know them better than me in terms of hematuria. Some patient may have to undergo TURP, fulguration of vessel, vaporization, cystoscopic clot evacuation, Helmstein balloon compression. Some patient, they may have to have irrigation with alum solution, etc. And if hematuria persists, then we go to more invasive surgery. So, you know, our purpose is really to convince our colleagues that the utilities, which they are convinced here, our urologists in our institution, they know that maybe PAE should be introduced a little bit earlier in the paradigm of the treatment of this patient with hematuria. So I'm just gonna switch gear here, talk about our experience in patient with retention. I think Dr. Bhatia spoke about it, so I'm just gonna fly over it. So essentially just a study that we published regarding the utility of PAE in patients who have retention and also have large prostate and have too many comorbidities to undergo surgery. So it's a single center series. I looked at the efficacy and adverse effect. 30 consecutive patients with a mean age of 73 years old who had associated comorbidities precluding them to undergo surgery. This is just a chart kind of summarizing a little bit how they were doing, how many days they were in urinary retention. Their quality of life was not great, and the prostate were large, 167 mean prostate volume. So these patients after PAE were followed by both IR and urology, and avoiding trials were performed within 2 weeks. If they failed, they were brought back after 2 weeks. So you can see that over time, some patient responded early, some patient we had to do avoiding trial until they were free of catheter. Both procedures were done early, our practice from a femoral access, and then switched to transradial. Most of the patient had bilateral PAE, and about 6% of the patient had only unilateral PAE. And the clinical success was high, was 86% of the patient. For patient over 30 or 13% was still unable to void after PAE and remained dependent on the use of a urinary catheter. So you can see these patients have a mean age of 83 years old. They have a comorbidity index of 7. And this chart just kind of summarized the whole data. So after PAE, all the markers, IPSS, quality of life, the prostate volume shrinkage, the Qmax, etc., were improving over the period of the follow-up. The adverse event, most of them were grade 1 adverse events that are self-resolving or resolved with conservative measure. And grade 2 event were 2 patients with urosepsis. This is such patient, a patient with urinary retention, 71-year-old patient. He was not really satisfied with the situation. He has been performing CIC for 45 days, had an indwelling catheter. So after the procedure, he was able to get rid of this Foley catheter. His prostate volume decreased by 37% from the baseline. So in conclusion, us interventional radiologists, we know what we can do with embolization. We have been doing embolization in the whole body to control hemorrhage. We intervene in trauma, we intervene in GI bleed, we intervene in gynecological hemorrhage, portal vein, etc. The only thing that we have not investigated is like using the PAE technique in hematuria. So we have used it in our series. It's has been proven to be safe, to be effective, to be highly effective in controlling hematuria, but it goes beyond. It goes beyond treating just the hematuria, because those patients who have been treated show, again, benefit in terms of improvement of their lower urinary tract symptoms, retention, etc. It also can be effective in patients who have urinary retention, large prostate, and they have too many comorbidities to go for surgery. We are revisiting the classical contraindication because we have been using more and more and expanding the role of PAE. And of course, multidisciplinary approach remains key. We work closely with our colleague urologists. They absolutely including the PAE in their paradigm, algorithm of treatment of hematuria specifically, and definitely, as a service, we get involved early in the care of their patients. So thank you for your attention. It's been a pleasure. I'm saying hello to all people from Agadir, which is a city that I still have family in, and I did spend I think my childhood vacation in Agadir. I hope you still have the beautiful beach, and it's a beautiful city. Thank you very much.
You will be always welcome. That's very impressive presentation, and it belies the experience and the expertise you have in this field. Thank you very much for accepting our invitation. I have just some very brief questions concerning the, let's go first to the CO2. Did you use CO2 in the gaseous nature, or is it in another form, like liquid, or you use like an air embolization of the artery?
Yeah, we use it in a gas form. It comes in a containers. There are dedicated now small delivery device that are made for a small container, handheld, basically the size of a smartphone that you can use to inject. There's another device coming on the market, mainly in Europe. We don't have it still in the US, not approved, that can actually regulate the flow and the rate of injection. So it does not really cause embolism in the arteries that we are exploring. Of course, there are some arteries where CO2 should not be used. Okay, for example, anything above the diaphragm, we don't use CO2 because of the risk for the heart and the brain. But below diaphragm, it's actually better. CO2 is a gas that diffuses very, very fast. That's why we are able to breathe.
Mhm.
If we could not diffuse, we will all die. So we use that property of diffusibility of the gas. It doesn't stay that much within the arteries. It diffuses very fast. And also it's more sensitive because the contrast is oily in nature. It's an oil, the contrast. So you need to inject more to see. The CO2, you don't have to inject that much, especially if you have a bleeder, for example. So our group are the first one to explore CO2 in the prostate. I think we have presented in the SIR. There's a lot of interest. We make it better by using some techniques, like, for example, balloon occlusion technique, that allow us to see those branches better. So definitely the reason we started exploring CO2, because we did not want patient not benefiting from PAE because they had issues with their kidney. So it's a way for us to expand the indications.
So does it stay? How long does it stay in the artery?
It diffuses immediately.
Very diffusible.
Yeah. As soon as you inject it, it's gone.
Lasting effect. Yeah, well, but if it's gone, the artery is not occluded, or how does it work?
So our machine
doesn't stay.
Our machines have specific protocols for CO2 angiography. Yeah. There's a specific timing to take the picture. So our goal is just to take the picture with CO2, not to keep the CO2, because it diffuses very fast. So we have specific protocol that we use in our
just just for mapping.
Just for mapping. Yeah.
Is it just for mapping, and then you inject the particles afterward?
Yes. Yes.
This is the yeah. One question regarding patients who come to you not through urologist, but didn't have workup they have a high suspicion of prostate cancer, didn't have the workup completed. Do you work them up before electing them for PA?
That's a great question. Yes, we do have patients that may self-refer themselves. They may have read anything on the internet or come sometimes from primary care physician. And then we do the workup, like, for example, we do an MRI and we discover a cancer. In these cases, we don't treat them. We refer them, we send them to a urologist to get their appropriate care, okay? Sometimes those patients are disappointed, but we make sure that they get the appropriate treatment. I don't know if Shivank has more input on that topic.
Issam, can you repeat the question? Sorry, I was responding to a text from a urologist, which I have.
The question was, if you receive a patient that come in self-referred, and during your workup, you find that this patient has actually, on top of BPH, has cancer, do you go ahead, proceed to do the cancer workup?
Yeah, absolutely. 100%. So, we get MRI on most of our patients, and if there is any suspicion of any type of malignancy, we will, the next step is to really get what is the new thing called 4K score. And once I get all the workup done, I work with my urology oncology colleague, and he reviews everything. And he will most likely end up doing MR, ultrasound, fusion, biopsy. And if the biopsy is negative, then he'll send back to me. If the biopsy is positive, then it goes on a different track. So, but the rate is not very high. I would say like maybe 3 to 5% at the max, especially if we do MRIs, if we do more MRIs, because, insurance does not authorize all the MRIs for BPH anyways.
Yeah, sure. And even for some cancer, maybe.
Yes, exactly.
Some cases you have to have negative biopsy, then you can refer the patient. In US, maybe it's completely different from what is in Europe.
Yeah.
One of the challenge you guys is the discovery of the anatomy on the table. So you have to discover some variant on the table. So this is how can you set up your table before? So what do you need as a catheter? What the diameter? So you have everything ready by the time you have your mapping.
Right now, after doing a few hundred cases, I think both of us have their go-to tools, the preferred tools. I think just like you surgeons, I mean, you probably have your preferred tools and material that you used. So, and I think, you know, with those preferred tools that we have, we are able to do approximately 90% of the cases. We do have backup special microcatheters, etc. We have sophisticated microcatheters that we can steer, we can change the shape to engage those difficult arteries. These are, again, very expensive. We don't use them all the time. But we do have all the tools and device. But at the end of the day, I think the skills of the physician are the most important, the knowledge of the anatomy. And then, you know, what I use is probably a little bit different from what Shivank used, but at the end of the day, we are able to do the job with the, you know, some basic stuff.
Some complementary things between the two teams.
Absolutely. Absolutely. Whenever I'm not able to get in, I call Issam. Whenever there is it goes Issam. Whenever I have, you know, CO2 iodine problem, Issam. So, you know, I can't survive without him.
This is the way to survive. Yes.
Yes.
Another question concerning patient with atherosclerosis where there is no usual anatomy. So you will have multiple small artery, tortuous artery. So how can you deal with this?
Issam, you want to take that? He does more of those than me.
Okay, so in our group, I'm known to be the unlucky one that get all of those. Shivank scrubs in, he finishes PA in 40 minutes. I have to suffer 3 hours.
And he's very picky.
No, he's great. He's lucky. So no, I'm just joking. He's amazing, talented physician, and his skills are like out of this world. So he's really able to treat physician and patients.
They say better be lucky than good. So I'm lucky.
No. I know you. So the problem of atherosclerosis is the main limitation of the procedure. Okay, because we need that arteries to be open to deliver treatment. If the arteries are shut down, some patients have total occlusion. There's no arteries. What can we do? There's nothing that we can do if they are closed. They have atherosclerosis. Some patients have difficult arteries, especially 70 plus, smoker, diabetic. It can be very difficult to manage. It's not like the young man. It's not like the woman. It's not like fibroid. This is different. So that can make it difficult. We have developed technique over time. We have developed some special tools, special wires, etc., that help us. And we believe to give the chance to all patients. You know, our group does not exclude patients. Some groups, for example, Portugal, they would scan the patient. They do a CT scan. If they see he has atherosclerosis, they will tell him you're not a candidate. They simply would not start the procedure. I think both of us, we try to give the patient the best chance and fight for them. And sometimes you're surprised, even though bad arteries, you're able to go through and deliver treatment.
Did it happen to you to have, sorry.
See, right now I'm dealing live with a patient.
Sometimes to have patient with bleeding associated with coagulopathy. And this is very challenging.
Yes. Yeah, of course, we deal with these patients. Either they have active bleeding and they are, for example, on dual antiplatelet therapy due to a recent myocardial infarct, having a stent placement, etc. So the fact that we are able to do it through the radial access has allowed us to push a little bit the indication and decrease the risk of bleeding, because radial access is, you can control the bleeding at the end with just one finger, as opposed to the groin. We can give you a retroperitoneal hematoma that can be very difficult or life-threatening.
In fact, I'm dealing with a patient right now who will get transferred this afternoon from 100 kilometers away from another hospital just to get PAE with us.
Okay, I think we covered everything. So you guys did an excellent job. That's very kind of you to accept our invitation. And we hope to see you soon in person in Morocco sometime
Thank you.
this year.
Thank you very much. Thank you. We really appreciate it. We appreciate the invite.
Thank you. It's a pleasure. Thank you very much. Thank you.
Thank you very much. And we'll extend our thanks to Mr. Qadiri and Cooper Pharma for covering this event. So thank you very much and have a good afternoon in US and good night for the rest of the world. Thank you very much.
Thank you. Good night. Thank you.